right, good morning, everyone. Thank you for joining us for yet another pediatric grand round. Today's speaker is Dr. Richard Cordle from the Department of Pediatric Gastroenterology. He is the Associate Professor of Pediatric VTC SOM and has been with the Carilion organization since 2002. Prior to that, Dr. Cordle served as a Chief of Pediatric GI at San Antonio Medical Pediatric Center and an attending at the Brooke Army Medical Center. In addition to his clinical duties, he serves as a preceptor to numerous resident students, a LACE preceptor, has recently signed on as the GI electives director for the pediatric clerkship, and reliably and exceptionally gives grand rounds every single year since he's been here, I believe. Please join me in welcoming Dr. Richard Cordle.
Welcome, everybody. I don't know, it's so hard to give these talks virtually. I feel like we need to, if I had like an audience like they do in baseball with cardboard pictures of everybody, maybe I would at least feel like I knew who was here. But I know there's a chat box, so if you have any comments, I'm going to ask for some audience participation, so feel free to throw in an answer. And then if you have questions at the end, hopefully we'll have some time, but I have a ton of slides. And we're going to go driving through those. But if we have some time at the end, please ask questions or email me or try to contact me if something stirs up. Not always do I remember to touch on everything. So hopefully we can do that. So let's strap on our seatbelt and hopefully, let's see. There we go. So I don't have any disclosures, but I will discuss some brand names. I know we're not supposed to do that, of things that people put it in their bodies, and that's not meant to promote anything, but just to give some awareness. So my objectives are to focus on particularly button battery ingestions, and because there's been some new information related to this that I think is good to get out. So I want to talk about how to mitigate it and prevent injury, get them here fast, transfer, and then quickly care for these ingestions. We want to talk about how by the type and of the foreign body that dictates management. We want to talk about caustic ingestions and how to recognize those and dispose of those patients in an appropriate way. And then aftercare, what makes sure that they are going in the right direction, that they're not forgotten if necessary. So so now we're going to play a little game, and what I thought we would do is go through a series of cases just to sort of whet our appetite. And if you only pay attention to this, you probably will get most of the points of the lecture, and then some of this will be repeated as the lecture goes on. So we're going to play a game called Should I Scope? So our first patient is a 16-month-old, bit off the end of a necklace. She's comfortable, and she's handling oral secretions. So should I scope? And you can throw things in the, if anybody wants to play, you can throw me some chats. So this is in the esophagus. Patient is comfortable, handling their oral secretions, no symptoms. I found this picture on the internet, so I didn't see this patient. So no one's playing. So you would go after that. So esophageal foreign bodies come out. The timing, though, like when you do it, is based on symptoms. Something up high like that in a child, probably you would want to get at pretty soon. I would doubt that child really, in essence, didn't have symptoms. And this is an exceptionally large item. But so the teaching is esophageal foreign bodies come out. The timing, it depends on symptoms within a 12 to 24 hour period, if not symptoms, immediately if symptoms, like within 4 hours. And this is a necklace piece that I did pull off. So Little Mermaid top SpongeBob SquarePants. All right, so this is a true case. 15-month-old was found in the kitchen by a sibling drinking a yellow substance from a water bottle. not from a cleanser bottle, but from a water bottle. Mother recognized it as the same stuff that she uses to clean up at a hotel. She informs the emergency room staff that it contains sodium hydroxide. And we'll talk about that later, why that's important. So she's taken to the emergency room. She's drooling profusely. Should I scope? And when? So to get further history, while in the emergency room, she had Benadryl was given, Ciamedrol was given, and an NG tube was placed. And so this is what was found at endoscopy. What you can see, I think my pointer works, what you can see is this linear ulcer that goes all the way down. In this picture, you don't see the NG tube because it was removed before this picture was taken, but there was one in. This is a side picture of the same ulcer, came from mouth to lower esophageal sphincter. So the teaching here is this is there's a classification scale called a ZARGAR classification scale, and this is important for disposition. And this child had a class 2A. Everything 2A and under typically will not have further symptoms, and so that this child will be allowed to go on and have some clear liquids under observation, and then be able to discharge home, which is what happened if they're able to handle it. However, and this child did well without any future sequelae. So what does this case teach? So the knowledge of the agent is important in predicting injury. And we'll talk about this, but sodium hydroxide is very alkaline, has a pH of 13 to 14. And it's the pH that will dictate the injury typically. And so something a strong alkali like that is going to, we want to get nervous about. The presence of symptoms like drooling is controversial, whether or not it correlates with the degree of injury. And we'll discuss that in a little bit more detail. And there's whether or not you should scope is probably a combination of was it observed, the strength of the agent, and whether or not symptoms, all those things are put together to whether or not you should go ahead and do a scope. Now, this child had a blind nasogastric tube placed. You do not want to do that. This is strongly forbidden. And you could perforate somebody, particularly if they have a class 2B or higher, at the time of presentation, you could actually cause damage. And so we'll talk about all this will make more sense as we go forward. And then the other teaching is, like I said, class 2A and lower rarely have problems. So this is just wetter appetite. This isn't the full lecture. So this is an 18-year-old with bulimia. This is not a case that I saw. Making this one up. So 18-year-old bulimia with vomiting and abdominal pain. And so see if you can see anything abnormal in this x-ray. So maybe a hint over here. I can't. There you go. What does that look like right there? So should I scope? So yes, and here it is. Here's the toothbrush. So toothbrushes are a frequent thing that bulimics use to sort of trigger their symptoms. And this child, this young lady went a little too far. So the teaching here that I wanted to get out is that large foreign bodies come out. So 5 centimeters long or 2.5 centimeters wide. These will have trouble negotiating the C-loop or the ileocecal valve. And even objects that are smaller, like a quarter, which is about 23 millimeters, 23.5 millimeters, might have trouble coming out if a child is, say, 1 to 2 years old. So that's still less than this, but still might have trouble, and you might want to go in and take that out rather than let it pass. But a large object is another criteria, even though it would be in the stomach. This is a true case, happened just this call segment. So 12-year-old swallows 2 toy magnets at midnight on a dare. So this is you can see these are 2 rare earth magnets. These are common now, much more common nowadays in toys and desk toys and stuff. It's particularly for people who fidget and want to play with something. This child ingested 2 of these. This looks harmless, doesn't it? It's in the stomach. It looks like it will pass. It's blunt. Blunt things tend to pass without problems. Should I scope? And the answer is yes, but there's nothing there. Maybe I shouldn't have done that. But the teaching is that small rare earth magnets, if there's more than one, you definitely want to go in and try to get them out if you can, because then you have to watch them in the hospital. And she spent the rest of the week watching in the hospital. Failure to remove them can lead to complications. They can get on either side of a loop of bowel and cause fistula and perforations. And we've had some recent experience with this. So here's another one. This is a 21-month-old who was observed ingesting a coin. Mother was looking for something in the cushions of the couch. She pulled, this is also the last call cycle I had. Mother was looking for something in the cushions of the couch. She pulled back the cushions. Toddler was sitting there, saw something behind the cushions, immediately grabbed something and ate it. She had no symptoms. She presented to the emergency room, and an x-ray found a radiopaque foreign body in the stomach. It was round. So mother denied any button batteries in the house. So question is, should I scope? And the answer is no, you could wait on that one. So blunt foreign bodies that are less than 5 by 2 may be left to pass if they're asymptomatic, particularly if it's like 11 p.m. or if you're in your office and a child comes to you and you see the family tells you that they've ingested this. There can be a lot of hysteria or worry about it, but you can reassure them that these will pass, and then we'll check again in a couple of weeks. There's no urgency here. I've had some patients referred to emergency departments because with urgency and telling them that we're going to pull this out, and then they get discouraged when we do not, and we will let these watch. And what we'll tend to do is bring them in on one of our scope days in a 2 to 4 weeks if it hasn't already passed, giving it time to go so they don't have to be sedated and go through a procedure. And we'll try to give it a chance to pass, but we'll bring them in during the light of day and check one of these x-rays and then go from there. So this happened also last call segment. I had four trips to the ER this last call week. This is a 13-year-old gamer. By the way, if you're eating something right now, you may want to put it down. This is a kind of some gross pictures coming up. So his microwave flank steak was a little too tough. He was eager to get started on his vampire killer game. And however, the steak was taking his time and energy. Cutting his losses, he decided to swallow it whole. Immediately, he could not swallow his saliva, and his drinks came right back. He presented to the emergency room, and the emergency room gave him a dose of glucagon. So glucagon is used frequently in emergency departments to try to allow some esophageal relaxation, and it didn't work. So should we scope? Yes. So, and there it is. This thing came out in block, and disgusting. But this is what's interesting here. So after that was removed, you looked at this esophagus, and this is abnormal. It doesn't on first blush look abnormal, but you can see these lines coming down here like this, and it kind of looks more swollen. And this is the picture for eosinophilic esophagitis, and his biopsies did show that. And so the lesson learned here is that the majority of time that you see a food impaction in a child rather than with an adult. Adults, this happens a lot. But in a child, that there's an associated underlying pathology. So that was all just to whet our appetite about, so you know that this happens. That was 4 times in 1 week that there were 4 foreign bodies. So this is a common thing that happens, and it's good to have answers to some of the people's questions, and then to know how to manage these, whatever setting you're in. So we're going to start off with, hold on, let me go back. So these are the things we're going to talk about, and hopefully time will allow us to also have some questions at the end, but there's a lot to talk about. We're going to talk about caustic ingestions of button batteries and magnets with some length, and then briefly touch on coins, sharp objects, and esophageal food impactions, even though we see those more frequently than the others. Just the others are much more clinically significant in their presentation. So caustic ingestions, button battery ingestions, and then magnets. So let's get started on caustic ingestion. So a report from 2014 looking at all ingestions of caustic substances found that children under 5 accounted for the bulk of those. The reason for that is that the toddlers become mobile and they search for things. And where we put our cleansers, they're usually in cabinets, which are toddler level. And that's where they go in. And usually, though, in children, they're low volume because they taste it, and usually they don't like the taste and they don't keep drinking it. The most common agents are bleach, oven cleaners, and then there's also like hair relaxers and cosmetics. Acids, which are also damaging, represent a minority of patients. However, now if we're dealing with a teenager or an adult who ingests, they tend to be much more significant because these people are going to take in a higher amount. This would be a terrible way to try to hurt yourself because of the lifelong issues that you have to deal with related to that. So the why these things are damaging relates to several different features. So first, the pH, and we'll talk about that. The concentration or the amount. You can have a lower pH but a higher concentration, and that could be more damaging. The amount of time that it's allowed to sit in the esophagus or the stomach, the amount ingested, as we mentioned, and then the form. If you have a solid like a dishwasher detergent that's in a powder form, most of the time a child will only taste that. It'll burn the lips and it won't go down, so you won't have as much of a injury to the esophagus as you might find with something that's liquid that will go right down. So pH. So I hope this shows this pH scale on your computer screen. But if it's less than 2, acidic, then that can be damaging. And then if it's greater than 12, these are the agents that we were worried about. Remember that one child had sodium hydroxide, and that put the pH way up here. Bleach can be anywhere from 11 to 13, since that's the most common. Here's oven cleaner. That's a problem. Pool cleaners are also very, very basic. And then toilet bowl cleaners are way down here, typically, although many of them are also alkaline. Liquid Drano or liquid plumber, those usually contain potassium hydroxide or sodium hydroxide. Back in the 60s and 70s, the concentration was 30%. Almost all those patients had trouble with those ingestions. And then in 1970, there was an act from Congress that tried to put a lid on this, no, I guess pun intended, to help with this. And so labeling to say this was poison, child protective coverings on the objects so you couldn't get at them, or that really limited the amount of problems that people had. However, we still have issues, and one of them is because unmarked bottles filled with a caustic substance. This is very common in Africa for some reason. There was a report from South Africa that they had significant amount of injuries, and I've seen a case. It was a Nigerian child who came to America who had a a caustic ingestion when she was young. This is just highlighted. This is a paint stripper that was on a boat. They decanted it into this water bottle, and they were using it to take paint off the ship. There was one of the workers on the ship was very thirsty, hot, middle of the day, and took a big swig out of this, had a significant esophageal injury. This is just to highlight that you don't want to do this. So I thought, my house was safe, and then I found this in my house, and this is my wife is a member of some kind of online cleansing. They send you these things in the mail, and these are nice, pretty packages. The girls tell me that one of these is obviously, Dad, blue means it's for, showers. This is for all-purpose or something cleanser, and another for yours. But these are cleansers, but in unmarked bottles. This was kind of dangerous. Fortunately, they're in these squirt things, so it's unlikely. But these are, fortunately, there's no toddlers in our house. But this would be bad if my children start having children and we have this in the house. We'll have to be careful with that. So why do alkali ingestions lead to problems? So if you harken back to chemistry, you know that if you take fat and you have an alkali with it, it's going to lead to soap. So you'll saponify that. It'll loosen or liquefy the mucosa. That allows for deeper penetration, and then you'll start to kill off tissue, and then you'll actually have perforation. Also, alkaline doesn't have as strong of a taste as acid, so larger volume could be ingested, and then it doesn't travel all the way because of the viscosity. It doesn't travel all the way to the stomach, and that leads to significant esophageal injuries. Acid, on the other hand, usually gets to the stomach, causes a scar formation and some ischemia at the site. You can have significant scar, eschar formation at the pylorus, which could lead to obstruction. But acids tend to be better tolerated. You're going to have more gastric involvement. So what kind of symptoms might you have? So we talked a little bit about symptoms at the beginning. That girl had swollen lips and she was drooling profusely. So drooling is a common sign. Vomiting. They might refuse to eat. They might have abdominal pain or hoarseness or stridor, or no symptoms. You might see redness of the mouth or lips, or a white patch in the mouth. They may have, if it's the airways involved, there may be some upper airway sound, some obstruction. There might be some respiratory distress. The problem here is that if it goes unwitnessed and a child just presents just with some of these signs, you may miss it. You might not be thinking about it. So you have a known ingestion. You want to find out what the agent is. We talked about pH and why that's important. And so sometimes we can feel a little bit more comfortable if they say this is just a 5% bleach. Bleach is 5 to 12% typically. If it was a more concentrated bleach, we might be a little bit more worried, or if there was a higher volume. And then we're going to look for signs or symptoms. How long ago was it accidental? Remember, purposeful ingestions are going to be much more worrisome. We're going to examine them, look at the mouth. You could do labs. There's some talk about heavy ingestions might cause some of these problems listed: hemolysis, DIC, or liver damage. I've not seen that to be as much of a worry. A chest X-ray to look for perforation and to make sure that you're okay, and then we base our disposition on all that. So this is the controversial topic. Do signs and symptoms tell us should we scope or not? And so to highlight that no, sometimes you could have no symptoms and problems. There was an old study looking at a lot of patients, and 12% of them were asymptomatic, yet they had severe burns. And a significant number who were symptomatic did not have esophageal injury, highlighting that maybe we can't really use symptoms to tell. A more recent study, again, looked at a lot of patients, and they had found that a significant number without oral lesions had esophageal burns. So this would make one think, well, I really can't comfort myself on the fact that I don't see any symptoms. It's particularly if there was a witnessed ingestion of something significant, like a pool cleaner or a liquid Drano. However, there's some other data that shows that if you don't have symptoms, chances of injury or if you have just one symptom, the chance of injury is low. So this group also looked at a lot of patients. If memory serves, I think it was near 500 patients. If they had vomiting or drooling, or they were asymptomatic, they found that they had a grade 0 or 1 injury. I'll show you what I mean by the grade of injury in a second. So they, but in this accompanying paper 10 years later, show that if you have 2 or more symptoms, so vomiting and drooling, or if you have stridor, also alone, that those were much more predictive of injury. And so we look at this algorithm. This came out August the 6th, so this is hot off the press. This is an article from New England Journal, and it's this comes heavy on using symptoms. So let's say that we're going to focus on this left side. So if you have an alkaline ingestion, unintentional, that's a majority of our population, asymptomatic, and you don't see any signs or symptoms, they're saying you could watch these people and send them home. But this is the group I want us to focus on. So one of the following, they're saying if you have vomiting, they're looking at the articles I mentioned that talked about symptoms, vomiting, drooling, or they're not taking anything, just one of those symptoms, that they could be watched overnight and then given a trial of clear liquids without having to scope. And then if they continue to have struggles, then you would scope them. Now this is the New England Journal, and this is what their recommendations are. I'm going to probably come heavy again. I'm going to lean maybe away from this. If there's vomiting and drooling, or there's stridor alone, you would want to go to endoscopy, and then you would want to grade it based on the level of injury. So because there was those other papers that talked about how symptoms didn't help, I think that we should, and others think, that an asymptomatic unwitnessed ingestion or an agent that's not typically associated with injury could be watched. You could offer some clear liquids and maybe likely discharge. If, however, it's witnessed and or you do have symptoms, or it was a strong alkali, then you would admit, keep them NPO, and you want to plan on endoscopy. Now, interestingly, you don't want to do endoscopy right away because you could miss the injury. You want to wait. So if they come in at 9 o'clock, you might want to wait till the morning. Or as all foreign bodies too, if they come in at midnight, then you could wait till the morning to do your scope, perhaps, because you want to let the injury start to show itself so you know what you're up against. If you go later than 24, really 48 hours, then the tissue there, after all that damage, starts to create very, very thin, fibrous scar formation that's very fragile and can perforate very easily. So you kind of have a window of time there where you can scope, and it's about roughly 8, maybe at the earliest, to 48 hours. I can admit that I think I tend to go early because I feel like many of these patients you can get a disposition more early, but I'm probably better to wait, particularly if you think it's a strong alkaline and there's a combination of those symptoms like we mentioned. So you don't want to do things that have been tried in the past, which is to neutralize it. If you try to neutralize an alkaline by putting some acid in there, or like acetic acid vinegar or something, you can create an exothermic reaction that can increase the temperature there significantly, up to 3 or 4 degrees Celsius in the stomach, and that's not you don't want to do that. You can put them on some a PPI and then consider some antibiotics because of the risk for perhaps perforation. So I've been talking about this classification scale, and finally I'm going to show it to you. So this is so 0 means nothing's wrong. This is a normal looking, kind of blurry, but it's a normal looking esophagus. This one is showing that there's some redness. So these two people typically are going to be fine. They're going to be able to bring them to the ward, put them on some clear liquids, and do fine. This one, you're going to be a little bit more cautious about your advance. This is 2A. These patients have ulceration that's non-circumferential. And in this case, this is a 2B. You can see it's much more significant ulceration, and it's circumferential. In 3, you can start to see these black necrotic elements. And then in 3B, it's extensive necrosis. And these are at high risk for perforation, even at the time that you're scoping. For 2B and higher, you would be tempted to actually thread, under guidance, a nasogastric tube at this time. These patients you're going to bring to the floor. You're not going to feed them. You may want to put a PICC line in because you might need TPN. But the NG tube is so you can have access to the esophagus, because this is going to scar in and start to stricture. And you may need access to feed, or even for later to put a wire or something so that you can have access to dilate these people. So this is this group. So we talked about the ZARGAR classification, grade 0 and 1, NPO, and then in 2A might go overnight. 2B, USTA is a recent study that talked about using steroids, and I'll show you that in the next slides. And steroids have been controversial in their use, but a recent study showed that if you're 2B, that you could use 3 days of steroids, and it might actually help them not to have complications. 3 and higher. 4, classification of 4 means you're already perforated at the time of presentation. So CT scan might be needed to look for perforation in these cases, because you're going to be nervous about complications. So these are really, really sick patients, they've already had significant injury. Fortunately, you won't see these very commonly. And this is a sort of a summary of what I've talked about. So 2B, NG tube. Here's the USTA protocol. 3 days of Solumedrol, high dose, 1 gram per total body surface area. And then and you can see the difference in the study in terms of the need for future dilation, 9% versus 29. That's significant change. Other things that have been done have been used Carafate in these patients, which helps with healing, and then a anti-fibroblast agent called mitomycin C can be put on a pledget and used to wipe the esophagus, and that prevents the scar formation. It may help with having less dilation. Grade 3 or higher, you're going to watch these people they're going to be in the hospital for weeks. They're going to need PIC placement in G-tube maybe, and you may need a water-soluble contrast to look for perforation before you start to do any kind of feedings. So complications usually occur later, usually after 3 to 4 weeks after the ingestion. If you're 2B or higher, you have almost a 3/4 of those could develop a stricture. 100% of those are grade 3, and we will then put them on a protocol of dilating them. You could inject them with steroids. Sometimes stents have been used to keep their esophagus open, and we're talking usually every 2 to 3 weeks for months, getting dilations until finally it holds. A worrisome thing is that in their lifespan, there's going to be 1,000-time increase of cancer in the esophagus. And so to drink an alkaline leads to a lot of lifelong complications. So this gets to, we don't want to see that. And so as part of your conversations with families, hopefully this will jar you into remembering to maybe mention this from time to time, even though it's not commonly done. I mean, we don't see these very much, that's what I meant. But not putting cleansers in unmarked bottles or anything that looks like a water bottle, and locking the cabinets is important. I just want to briefly touch on this. You've seen this, all of us use these little detergent pods, and these look tasty. They're colored, particularly those ones that have like the blue or green. They look like they might be good to eat. And so a toddler might want to put those in. And you can see there's been this is the pod ingestions over time that you can see that these are really, you can maybe draw a line upward. There's an increase in incidence. This is just over 1 year period. I just want to highlight that that this is 60% of the detergents were ingested this way. Really young kids, there's been as you can see, a slight increase. This is what I wanted to tell you, is that sometimes they'll have CNS features. And I remember taking care of one of these kids, and they were just sedated for almost 24 to 48 hours before they started to come out of it. So we're going to move on to button batteries and talk about. I'm just going to stop there for a second. Are there any? Is anybody listening? Is there any? If anybody has a question or anything, just throw it up. Anything on caustic ingestions that makes you think I want to know something now? Then send up a question. But seeing none, so we're going to move on to button batteries. So this is an emerging problem. So in 1992, the National Capital Poison Center reported that there were 2,300 ingestions that they had accumulated over the previous decade, and 2 of those had been strictures and no deaths. That seems like these people do well. However, in 2010, 18 years later, 8,600 cases, some more cases, longer time though to collect those cases. However, much more injury with these. Seems low when you write down 0.8%, but that's a significant increase over those from the previous ingestion. And then there was actually mortality. Mortality came from perforation, and then the dreaded aortoesophageal fistula. So they eroded through the esophagus into the aorta with massive life-threatening exsanguination. So a significant worry. So why? Why is there this increase, and why are they much more damaging? It's because of the use of lithium batteries. So before they were alkaline batteries, they still use a lot of these zinc air batteries. and those are less harmful. But now that these lithium batteries are larger, they're 20 millimeters, whereas previous were 12 to 16 millimeters. They have a longer shelf life, so they're used more. They have better stability, and so that's why they're being employed in many products now. And then, as you can see, the number of ingestions that present because of the size and the power went up. And that's their 3 voltage. They're 3 volts rather than 1.5 volts. And this leads to the problem. So if you have a 12 to 16 millimeter battery, it doesn't have as much power. It's not going to get lodged in the esophagus as much. It'll go on down to the stomach and most of the time not cause injury. And that's why the previous report didn't have as many problems. However, if they're larger and they're much more powerful, they're going to get lodged in the esophagus and cause problems. And this is demonstrated on this graph. This is not coronavirus cases. This is button battery ingestions over time. So this is July 2002. This is 2016. The little blue lines are the number of cases that were major or fatal over time. And you can see that with an average line, that those are going up in time. This is the number of cases of button battery ingestions that presented. And you can draw a line through that, extrapolate it, and you can see that those have gone up also. Where do the people get these things? So the majority are coming from remote controls, watches, and game toys. Remember those fidget spinners that drove us crazy? Some of those had batteries. These flameless candles are a significant number. Here's a scale, and so many things have these in here. And I had a case where a kid, he was, I think 4. He was 4, and he had taken the thing out. He was just curious, and he popped the thing open and saw the little thing in there. It was shiny. Put it in his mouth. This is also another graph demonstrating what I showed you earlier, but this is to show you that in the 90s and 80s, there were still frequent ingestions. They just didn't present because they didn't have these larger batteries. And so the diamond line shows you how the number of significant outcomes and worsening over time. So the number of cases actually of ingestions has not necessarily increased as much as the complications related to them. So why? Why does it cause so much trouble? It's because when they get lodged in the esophagus, a current is generated across the mucosa because it's opposing both sides. And then it'll start to, if you remember from chemistry class, go take a 9 volt, put it into some vinegar, water, and see what happens. You'll see bubbling happen. And then if you go back and check in about 24 hours, you'll start to see a collection of a precipitate on one of the poles. And that's because there's also a chemical, it's electrochemical reaction. And so hydroxide radicals are liberated on the negative pole, the smaller side of the battery. So, and this is going to raise the pH rapidly from 7 to 13. And you just saw, that's the reason I put the caustic ingestions first, is to show you the damage that raising the pH would do. And so it'll raise the pH rapidly within 30 minutes. You can see injury within just 15 minutes from an ingestion, stricture in 30 minutes, and go all the way to perforation within 2 hours. So this is an emergency if we can catch it. So the mucosa and the structures nearby, the negative pole, are likely to be at risk. And so if it gets lodged in the upper third of the esophagus, and that pole is facing the aorta or even the spine, there's been some spinal involvement, you can see how the associated tissue nearby is going to get damaged. And this is shown in this pie chart. So, so spine has been involved, vocal cord paralysis, pneumonias, ulceration, damage to the tissue nearby, perforation, these dreaded vascular fistulas happen, and then some just unreported cases. So how might they present? Many are unwitnessed, and those are the ones that are dangerous, but they might come with just non-specific symptoms like vomiting, dysphagia, irritability, tachycardia, cough, hematemesis is worrisome. And so, and even if x-rays are obtained, you might blow it off because it looks like a coin. And so if you look at this picture, you can see that these coins are similar in size to these button batteries. just for grins, these are the lithium batteries, and you can see they're 3 volts, and these numbers tell you it's 20 millimeters, and then it's 3.2 millimeters in depth. That's what that number means. So if you learn nothing, you got that. So so this slide is just to show you how they resemble coins. And then on X-ray, what you can look for in X-ray is this is a coin up in the esophagus. This is a button battery in the same place, but they'll have this halo sign if you can get a good enough picture. So you want to cone down, zoom in on that. And then on the side, there's a step off. So you can see the step off. So you want to get a lateral. So that's a teaching on this. And I think I have not pushed for laterals as much as I should on these patients that come in with these proximal esophageal foreign body ingestions. So get a lateral and look for this halo sign, because it's going to change what you do. This is an algorithm, and I hope this isn't too busy. This comes from an important paper. This is from our society. These are guidelines for 2015 that has a paper with a lot of algorithms. And this is just to show that if you find it's in the esophagus and they're stable, you definitely want to take them immediately to the procedure room. Don't worry about whether or not when they ate last or anything like that. You want to take them in, rapid sequence induction, and then you want to take that thing out. However, if there's bleeding already, where they seem clinically unstable, you want to make sure that your surgeon is aware, because there could already be damage. And then you still want to take them to the OR to take it out. But then afterward, if you've seen that there's been significant esophageal injury, you're going to worry because the complications could come later. So you might want to get some chest imaging to see where there might be imaging. I'll show you a picture in a second about that. So if you take your imaging, doesn't seem to be any associated soft tissue damage, then you can watch this patient overnight or maybe 2 days, do another esophagram to make sure there's no leak, and then start to feed them. However, if you do see injury, you're going to watch until that injury seems to go away. You have to nourish them by vein. And then if they develop any kind of complication like hematemesis, you may even need to get a CT surgeon in there immediately, because this could be an aorto esophageal fistula. I think there's been 1 survivor from one of those. We're not talking about this right now, but if it's in the stomach, and they, we'll come back to this, but if it's in the stomach and they're young and it's one of these big lithium batteries, you still might want to take it out. This is a controversial area here, is whether or not you can wait if they're older than 5. Should we just let it pass like any other foreign body? And I'm going to talk on that. So this is a patient who had a significant esophageal injury, and you can see the swelling here right near the aortic arch. And so that would be a patient you would worry about. So the complication could be delayed. This will just give you a nightmare. So this is a patient. There's a case reports. This was a 16-month-old presented, had a button battery in the stomach a week prior, who presented with hematemesis. So what had happened was, yes, it was in the stomach, but it had already done damage to the esophagus. But because it was in the stomach, they blew it off and let the child go. Presented a week later with some hematemesis. They scheduled the patient the next day, or hematemesis. They were getting ready to schedule the patient for to go into the OR, and the patient just exsanguinated and passed away from a aorta esophageal fistula. So with the amount of damage, and you can imagine a patient from White Sulphur Springs gets one of these. It's going to take them 2 hours to get here. And by that time, it's late. Damage is done. And then they come into the ER. We have to get an X-ray. It takes 45 minutes for my endoscopy team to come in. These are delays that I think we have to work on. But is there something that we could do to help prevent some of this injury beforehand? So some people are looking at this. I'm really messing up. So there you go. So this is a paper done recently. These are pig esophagi. I think that's the plural of esophagus. And so this is just looking at different neutralizing agents to see the level of injury. And you can see oils tend to do well. And this got some people thinking. So one one investigator looked at cola, lemon, acetic acid, and orange juice, and they showed improvement with all those, just like you saw in that. And then, but those aren't, a lot of people don't have those on hand very easily. And yet one used honey and showed that in piglet model, no complications related to those with controls. And then another investigator looked at what happens if after we take the button out, we wash the esophagus with acetic acid, trying to neutralize some of that alkaline, and washed it with up to 5 ounces of fluid. And they've actually tried this with 6 pediatric patients, and all of those did not have strictures afterward. So this leads to a protocol, even though this has not been prospectively analyzed. This is what we should do. So if you get a report, if somebody has a button battery ingestion, you want to give them honey, 10 milliliters every 10 minutes for up to 6 doses if under 12 hours from the ingestion. Then when they get to the hospital, you might have Carafate on hand. You can give them 10 mLs every 10 minutes. If they're under 12, you don't want to use honey because of the botulism worry. So you want to, you could use Carafate in that situation, but the people aren't going to have Carafate at home. Still want to get a rapid sequence induction despite all that, and then afterward wash the esophagus with acetic acid, which I found is on hand in most endoscopy suites. So this gets us to the gastric question. So what should we do then? You saw that one 16-month-old patient had a button in the stomach and then yet had this bad complication. So that one would be over here, less than 5. It was a 20 millimeter. So that one would have gotten scoped based on this algorithm. But however, the guidelines say you don't have to do that if they're over 5 and it's less than 20 millimeters. But there's been some concerns that even down to 15 millimeters could give problems in the stomach. And then it also gives, if you scope, it affords you an opportunity to assess for that esophageal injury. And then there's now some evidence. This is a later, that the gastric injuries may also occur even early on. And so this is a 2020 paper looking at a series of patients who had gastric button batteries. And you can see this is the upper bar is pre-removal and lower is some of the damage. So here's this an ulcer bed here, bleeding. There's another ulcer bed where this one was resting. There's been one case of perforation from the stomach. So it really makes you pause about sending one of these patients home when they have a button battery in their stomach, even though they're older and it might be smaller. So the temptation would be, it might be wise to go ahead and take these out. Maybe you have you can walk rather than run to those patients. All right, so burning through some time, but we're going to spend a little time on the magnet ingestions and then really just one slide for all the others, and hopefully that'll leave 5 minutes for us. So look at these magnets. So they look pretty. These are pea-sized magnets. They're rare earth magnets, and they were been out since the 80s. They were initially used in electronics. You'll find them in your MRI scanners. They're in computer. They have computer applications. But they're also were marketed as a toy to children in the early 2000s, but that's voluntarily, not voluntarily. They were voluntarily recalled by Mattel. But then they started to get marketed to adolescents and adults for like office toys to put on your desk, something to decorate your desk, and then people could fidget with them. And you can make necklaces, you can twist them around, you can make loops, and that sort of stuff. They're 5 times as powerful as your regular refrigerator wall magnet, refrigerator door magnet. Teens have used them to put, in their tongue to look like a, you can do a temporary piercing. You can put something on the other side and be, I guess, accepted for that. And then, but you can imagine that they could dislodge really easily and go on downstream. Because of multiple hospitalizations and some well-publicized complications, it led to the Consumer Product Safety Corporation restricting the access to these. But a judge overturned this in 2016, and you can see this is a Washington Post graph that I regenerated that shows the amount of ingestions are skyrocketing. And I was just telling Dr. Permeshwar that I've just seen 2 cases just in the last 2 months that I hadn't seen in the last 2 decades. And just to illustrate the problems with these, this is one of the cases. So this was in May. And so this is a 10-year-old who has the habit of eating edible objects. His family has to sew him on the bed because he just chews the fabric on the bed. So this family gives this type of boy these string of these magnets to fidget with, and so he started to complain of vomiting 2 weeks prior to coming to the emergency department, and then the night prior, he had a repeat bout of pain and vomiting, and it led him to come in. He still did not admit to ingesting them, but this is the X-ray. You could see this necklace almost of batteries. There's probably 40 or 50 of them in there. So I thought, well, maybe this is maybe there some of these at least are in the stomach, and maybe it's looping around the small bowel. I can get to it and be the hero and pull this out, and then we would hopefully let this pass. And so look at these images. Oops. So this is the stomach. Then I poked my head into the small bowel. So nothing was in the stomach. And this is what I saw looking at me. So I put a Roth mat around it to try to get the top of that. And I got maybe 5 or 6 come out. I had 5 or 6 come out. So then I went back down and looked, and I saw a few more in there. Now, what's interesting, you can see these coming out of this little thing here, is that if you look, the lumen is that way. I'm up here. So where is that going? This is after I removed them, and here they are in the specimen jar. So I got a pretty good segment of them, and they were coming out of this. Well, that led my sphincter to tighten, and you can see that this is a fistula because of the significant power of these magnets. So surgery was consulted. We admitted the child. We started him on a grow light lavage, and we watched him every 8 to 12 hours to see if we could get the rest to pass. However, they didn't move, and he went to the operating room. So in the operating room, he had 4 fistulae there, had a significant surgery. Took him about 10 days to re-establish bowel function. He was in the hospital for 2 weeks, needed TPN. So this was a significant hospitalization, and underscores that magnet ingestions are no walk in the park. So often these things are unwitnessed. Multiple magnet ingestions, just like this 10-year-old and the 12-year-old I mentioned at the beginning, are the ones that typically will eat more than one. A little toddler might come up and grab one. You can imagine the picture of a toddler coming up and just putting his mouth over, and trying to gum things in the environment, just learning how to walk. That'll give you pause. So the symptoms might be like this boy, some vomiting, some abdominal pain. And then your complications, as mentioned, could be perforation, fistulae, necrosis, obstruction, and damage. So how do we manage them? If they're a single magnet, you could go in and take them out if they were in the stomach, because this person might swallow something else, or something external, a metal piece or a belt buckle or something could pull that magnet, and that could actually cause some trouble. So you could, but for the most part, be safe, particularly if you're in a more remote area. You'd be safe to send them home, but you want to do some serial x-rays. How often should you follow them? I think prudence, maybe every 1 to 2 days to make sure that it's passing. Multiple magnets, though, if they're in the stomach, you want to go after them. If they're post-gastric, then you need to admit them and do serial x-rays to see if they're traveling. And you want to use some lavage, Miralax, or Go Lightly to try to get them out. You want to get your surgeons on board, because if they stop moving and or they become symptomatic, then they need to go to have surgical removal. Or if it looks like they've made it to the colon, maybe we can get them from the south end. So this is a very busy slide. This is just to show you that on the left side, these are single magnets that you can probably send them on. You could take them out. And then on the other side here, if you want to go to try to get them out, if you're successful, you might be able to discharge Otherwise, you want to watch for sterile X-rays. All right, so coins are our more familiar friends. They are the most common thing that children will ingest. Over a 10-year period, there's been 250,000 ingestion. There are some fatalities. Pennies are the most common, possibly maybe more dangerous because they're laden with zinc and some nickel, and that leads to esophageal inflammation and can erode through the esophagus. They account for almost half of the coins ingested. And if you find the coin in the distal esophagus, they often will pass even before you get to endoscopy. But you remember the dictum is that if it's esophageal, we take it out. Symptoms dictate the timing. So quarters are most likely to get lodged also because of their size, and they may even occlude the antrum of the stomach. So symptoms might be refusal to eat, some drooling, respiratory distress. So a child might come in with a chronic cough, and I've had that coin in there for a while. I've seen that, and might have a cough, even asymptomatic. The three places you'll see it the most common is at the thoracic inlet, like this picture here. You might see it at the aortic arch, and then a lower amount at the very end. You can imagine if it was in penny that it erodes and it's at the aortic arch that we might have trouble. So you see that the penny there is looking at us. It's on FOS. If you see it, you know it's esophageal. If it's on the edge, then that's airway. It's in the airway. You can do a lateral to make sure, and also get a lateral because of the worry for button battery. So at endoscopy, this is what it looks like typically. And then you can see this is just, this has been here for just hours, and you can see the irritation to the esophagus already just after hours. This is a penny. So if it's, again, if they're symptomatic, you want to take them out immediately. Symptoms not handling secretions or stridor. If not, then you can maybe wait if you need to, or you can come in and take it out then. So, and as I mentioned, if it's prolonged, you might have some significant complications. If it's gastric, just like the presentation, the one at the beginning, we might watch as an outpatient and then x-ray every couple of weeks. And then we can do an elective removal if it's not passing. If they develop symptoms or pain, then you can then take it out. Larger foreign bodies like the toothbrush, or maybe even a cylindrical battery, you might take out earlier. All right, sharp objects. So here's a screw sitting in this stomach. I've taken out 2 wood screws, and then certainly other things. So these are some of the common things that are ingested. And then, interestingly, if it's blunt on one end like this and sharp on the other, they could travel through the GI tract safely. So because the blunt end trails, and so if the advancing points puncture, and it's not advancing, then it's not going to puncture. So if it's asymmetric like this and it has passed the stomach, you definitely want to follow it radiographically, but it's possible it's going to pass. So really small, like a thumbtack or something that's asymmetrical might be able to pass. We certainly, however, if we can get to it, we want to try to take it out. If it's gastroduodenal, we want to go after that if we can to prevent any worry, because they can get lodged at different places. So this underscores the problem that if it's not metal, that it might be difficult to see, that there's some significant complications, perforation with abscess, might even go into another organ, and then even appendicitis. So here's a case of that. This is a child from Syria who ingested a sharp object, got into the, I didn't realize the time, got into the appendix. You can see that they had to go to appendectomy. So if it's esophagus, urgent removal is all things. Stomach, you want to go after it. If it's small bowel, you want to keep watching it. And then you might need to follow those in the hospital until you've waited for the 3 days for it to pass. And then if it's radiolucent, you might have to do further imaging to get to it. Food impactions are more common in adults. As I mentioned, glucagon doesn't help. And then frequently, this is to show you that we can use these caps now and pull it out all at once. And then lastly, that often there's associated pathology with it, maybe a tracheoesophageal fistula, achalasia, a reflux esophagitis, or what we see commonly is eosinophilic esophagitis. This is a common presentation for that. So we have just a minute to do some questions. So what I'm going to do is just read the question and then have you look at the answer. I'll just read the answers and then give you the answers. So which of the following are true statements regarding the timing of endoscopy for foreign bodies? So I want you to list all that are true. So blunt foreign bodies in the esophagus can wait up to 96 hours for removal. Is that true? No. Remember, all foreign bodies in the esophagus have to come out within 24 hours. So button batteries in the esophagus should be removed or emergency less than 2 hours. Yes, you want that out. C, a child with steak lodged in the esophagus and drooling should receive a dose of glucagon, and if this fails, remove the steak in the morning. No, you want to take it out then because they're symptomatic, and remember, glucagon often fails. D, a penny in the esophagus and symptomatic should be removed ASAP. Yes, because remember, symptoms with a penny, you want that out. E, 2 magnets in the stomach can be watched and do serial x-rays over the next 2 weeks. Is that true? No, because you know that the 2 magnets going down could cause injury. You want to try to get those out if you can. Here's my second question. Which of the following is a true mitigation technique? Remember, this is what we do before they hit the hospital. So is apple cider vinegar one? I put that in to confuse because of the amount, but no, that's not, it might work, but hasn't really been tested. Honey is available and we use that. So calcium carbonate, you don't want to use 1/4% bleach. No, it's 1/4% acetic acid after the battery is removed. Bleach would be adding a caustic injury to it. So third, a child has ingested coin and you find it in the stomach on x-ray, he's asymptomatic, you should. No, you don't immediately remove it. You don't send him to the ER and say the GI doctor is going to remove it. You don't put on go lightly. You do an x-ray in 2 weeks. You don't admit him to the hospital and do serial x-rays. You reassure. And then you can, unless you think it's a button battery, you might want to send that one in. But to discharge the patient with no need for follow-up, you don't want to do that. You want to keep track of that patient. So I'm sorry I went to the end. I thought I was going to have time. Any pending questions?
Someone want to know, have you ever experienced a patient having eaten one of those laundry pads?
I have. It was about 5-6 years ago. I think Dr. Powell and I took care of the girl or the toddler, and we admitted her to the PICU, and she didn't have as much caustic injury as she had just sedation and difficulty breathing with it. And that was what was so weird. We did keep her NPO, and we watched her for about 24 hours and advanced her if my memory serves. But it was that sedation part that was kind of creepy that needs to be remembered.
And Dr. Gard had a question on, is there anything that you can do to, after ingestion of a button battery, to slow injury until they're able to get to the ED?
So that's what the stuff was about using honey.
Oh, okay.
And so you can use honey, but they need to get to the ED and immediately, and probably call 911 to get them there, so they get there fast, and then maybe call ahead to the ER to let them know they're coming, and so things can start being ramped up. And then you can tell them to go get some honey out of the cabinet and take it with them in the car in the emergency vehicle. I doubt the emergency vehicle has that, so they can start taking it. I had a button battery this last 6 months, and fortunately the girl did fine, but I did have her do some honey and she vomited. But so it didn't in her case didn't work well. But that's what we're recommending.
Dr. Dixon had a question about needles.
What was the question?
She wanted to know about needles. What would you do if someone had swallowed a needle?
So a needle has a point on both ends, and they could potentially pass, but since they're not blunt on one end, that might be a challenge. We would want to get those out. If it was post-gastric, you might, on that case, watch that kid a little more carefully. You may want to watch in the hospital and watch where it's going to go. The worst case, or the most liberal, would be to send them home and check x-rays every day, having them come in with symptoms. But I think I would err on the side of letting them stay in the hospital and watching if you missed it, like if you couldn't get them out from the stomach. It's a good question.
And we had a question about a chicken bone that seems sharp on one end. What would you do with that?
It depends on where it is. If it was, again, it's a sharp end, and plus it's going to be hard to find on X-ray, perhaps, and because the chicken bones are heavy cartilage, and so you may not see it. But if it was blunt on one end and sharp on the other, I'm presuming, then you would want to try to get those out. If it was blunt on both ends and short, you may let that one pass. If it was like you had both ends of the joint on that bone, then you might let that one pass. But if it was broken, say, and was sharp on an end, you would want to try to get that out. Fishbone is much more worrisome because they get lodged in the esophagus and can perforate very easily. But a chicken bone that is in the esophagus needs to come out, and then in the stomach, if you missed it, you may be okay. You may make it without any problems, but you're still going to want to probably watch that child radiographically until that thing has a chance to move through.